Welcome to Rev MD, a podcast created for healthcare professionals by healthcare professionals. We will share tips on medical billing and coding, as well as workflow optimization to help practices succeed, thrive, and grow revenue. This week, we're going to talk a little bit more about telemedicine. And my original plan today was to talk about the recent CMS proposal for 2023 and the telemedicine guidelines that were published in July, along with telemedicine and mental health. Now, I'm still going to go over those nuances, but I want to share something that's even more hot off the press. So recently, the House passed the Advancing Telehealth Beyond COVID-19 Act of 2021. For short, that's the HR 4040 bill that could extend telehealth flexibilities through 2024. So as you guys know, at the beginning of COVID, in-person healthcare restrictions led to widespread access barriers. So in March of 2020, Congress had enacted legislation that expanded telehealth access for Medicare beneficiaries. And of course, this led to a huge rapid uptake of the virtual care platforms that we see and really just changed the perspectives of care delivery. So in March, the spending bill, which included several provisions to extend telehealth flexibilities, then became law, again in 2020. But it only extended the flexibilities for 5 months after the public health emergency officially expired. Specifically, this recent bill that was introduced actually seeks to continue the flexibilities to increase the number of geographic locations from where Medicare beneficiaries can receive telehealth services. That bill that went to the House also is trying to increase the number of virtual care services that can be offered by physician assistants, nurse practitioners, clinical nurse specialists, and many others. It's also intended to extend Medicare reimbursement for telehealth services provided by federally qualified health centers and rural health centers. And it's also allowing virtual mental health services for up to 6 months without an in-person visit. Now, there are some exceptions to that 6-month visit, which we'll talk about later. It also aims to extend the flexibilities related to the coverage of audio-only telehealth. So again, like I mentioned, this House bill was just introduced and passed recently within the last week or so as of this recording in August of 2022. So after a 416 to 12 vote, the House passed this HR 4040 bill, and it's being sent to the Senate. So we're going to have to watch this closely because it may change the landscape of telemedicine. So for now, I'm going to discuss the CMS-related release that came out in July regarding these proposed new rules on telemedicine that were supposed to go into place in 2023. But as we watch the Senate and this HR 4040 bill that was just passed by the House, this may all change. So I didn't want to delay the episode because I know folks are interested in hearing about the CMS proposed ruling for 2023. So we're going to chat about that. And then as soon as the Senate votes, I'll come back and kind of give an update on where we hear things. Now, as I always say, the information I share is for education purposes only. I am relaying and talking about information that's publicly available. If you have questions or concerns about your own practice, please contact your legal team or your certified billing team. So under the new CMS proposed ruling for 2023, if these are enacted, there's going to be several things that would change. And I repeat, these are in contrast to what I've said previously regarding the House bill that's being proposed or that has been passed. So please know I recognize the inconsistencies here. I'm trying to share with you what the House bill has in place, which I shared, and then what CMS is proposing, because it's going to be important as we go into the rest of the year planning for 2023. So again, the CMS proposed ruling creates 3 new permanent telehealth codes for prolonged E&M services, and they are actually proposing to discontinue the use of virtual direct supervision, which we'll talk about, as well as discontinue reimbursement of telephone or audio-only E&M services. They're adding a number of different codes to this telehealth Category 3 list, which I'll talk about. And they're extending coverage of the temporary telehealth codes until 151 days after the public health emergency ends. They are also trying to propose postponing the effective date of the Telemental Health 6-month in-person visit rule, also until 151 days after the public health emergency ends. Now, there are some exceptions to that, which really center around substance abuse disorders, so we'll talk about that in a minute. So reading between the lines, right, the nature of these comments and the changes proposed are really to suggest that CMS rulemakers anticipate this public health emergency to end sometime in the first half of 2023. They have stated that certain services added to the Medicare telehealth services list are going to remain on the list through the end of 2023, which is really going to allow CMS to evaluate which services are going to be permanently added and then how they're going to handle this really evolving landscape. So please to remember, we've got to keep track of this House bill. We've got to keep track of what CMS is going to do about it. Now, there was the Consolidated Appropriations Act, so CAA, which was enacted and removed the geographic limitations or restrictions and added the home of the patient as a permissible originating site for telehealth services for the purpose of diagnosis, evaluation, and treatment of mental health disorders. So that is done. Now, there are requirements that outline that there must be an in-person non-telehealth service with the physician or practitioner within 6 months prior to the initial telehealth visit. And then in-person non-telehealth visit must be furnished at least every 12 months for these services. Now, there are some exceptions to the in-person visit requirement, which may be made on certain patient scenarios that are going on clinically, but you just have to make sure that you're documenting those reasons in the medical record, of course. So CMS had also amended the current definition of telehealth services using interactive telecommunication systems. Now, really what they're trying to get at here is they really want both audio and video. And so they say that they now include audio-only communication technology really to only be used for telehealth services for the diagnosis, evaluation, or treatment of mental health disorders. And so really, this is basically saying you really need to be using both audio and video when you can. There are some exceptions to this when you have a patient that, say, can't access any sort of video platform, but you have to be able to offer that and be able to document that the patient is incapable or doesn't have access to video platforms. So just to be clear, CMS finalized a new modifier for services that are going to be furnished by audio-only communication, basically letting them know that this is going to be audio-only, but then you have to make sure that you have the capability of providing that two-way audio-video technology. It's just a situation of the patient, or it's a circumstance where you're treating mental health services for treatment of substance abuse disorders, where they would allow that audio-only technology. This all leads into the discontinuation of reimbursement for the telephone audio-only E&M services. So under the PHE waiver, right, CMS allowed certain separate reimbursement of telephone audio-only E&M services, which were those CPTs 9941 through 9943, something that was really embraced by a large number of not only practitioners and physicians, but also patients, especially those in rural areas who didn't have broadband access for video. Now, CMS did reject the request to permanently add these services to the Medicare telehealth services list, of course, with the exception, like I mentioned, of the telemental health services, substance abuse disorders, or in those circumstances where patients don't have access to the video option. And the reason for this really came down to the Social Security Act, which requires telehealth services to be analogous to in-person care by being capable of serving as a substitute for the face-to-face encounter. So CMS actually even said, and I quote, "We believe that the statute requires that telehealth services be so analogous to an in-person care that such the telehealth service is essentially a substitute for face-to-face encounter," end quote. So essentially they're saying, hey, we get it. We just really think the Social Security Act requires that face-to-face interaction. Therefore, 151 days after the PHE expires, only audio, telephone, E&M services were going to revert to their pre-PHE bundled status under Medicare. So that basically meant it was covered but not separately billable, right? So you're not going to see that separate reimbursement. Now, again, I'm excluding mental health, excluding substance abuse disorders, and potentially even excluding all of this together, right? Because the House bill came through saying they are going to allow that. So I know this is conflicting. Just recognize that CMS is trying to say that we're not going to reimburse for the audio only. The House bill is saying, let's keep it. And there are some exceptions where it may make sense to continue the audio only, especially if you've got mental health situations going on or patients who don't have access to the video technology, but you're going to have to document. And obviously watch for the news as this comes down, and also watch for your own specific payer policies, right? Because we're talking Medicare. And while many of the private payers follow that, we don't exactly know what's going to happen with the private payers. And so if you're providing these services today, I highly recommend reaching out to your billing team, asking, to have them review these contracts, have them review your current payer policies, and then watch for these changes very closely. Let's talk a little bit about what telemedicine modality is going to be required for telemental health services while the patient is located at home. So again, we're talking about mental health services here, right? And so basically CMS is saying that under certain circumstances, right, that two-way audio only technology is going to be allowed. And that's really going to be if the patient is located at their home at the time of services, the distant site physician or practitioner has the technological capability at the time of the service to use that telecommunication system, which would include video. Basically saying you have the ability to do video, but because it's a telemental health situation or a patient request, you're not using that, right? You're just using the audio only. Or in a circumstance, right, of course, that the patient is not able or capable or is not consenting to the use of video technology. So all of the circumstances are saying, hey, we've got a mental health patient. We've got circumstances where they're at home and I have the capability of doing video, but for some reason the patient cannot, or the patient is not consenting to. And so CMS, because of all of this, created this service level modifier to use in these situations where services are furnished to a patient in their home using audio-only communication technology, but you're capable of doing the video. So hopefully that makes sense. And again, I know a lot of this is still up in the air. And I think a lot of this is also CMS is really trying to really make sure that we are serving the need for this patient population. And I do think that a lot of this is going to evolve, especially with this recent House bill. I think the trend for telehealth is really going to continue to open up. That's just my personal opinion, but that's what I'm thinking. So we want to talk a little bit about what is defined as a patient's home for the purposes of this bill. So CMS did make mention that they define home, both in general and for this purpose, more than just the patient's primary resident, and can include any sort of temporary lodging such as hotels or homeless shelters. So for circumstances where the patient, for the privacy or personal reasons, chooses to travel a short distance from the exact home location during a telehealth service, the service is still considered to be, quote, in the home of an individual, end quote. So for the purposes of this rule, they are kind of extending the definition of truly at home. Let's shift gears a little bit and talk about the proposal for the discontinue of the use of virtual direct supervision. So under Medicare Part B, there were certain services like testing and other professional services that must be furnished under the direct supervision of a physician or other practitioner. Now, for Medicare purposes, direct supervision requires the supervising professional to be physically present in the same office suite as the supervisee and immediately available to furnish assistance and direction, right, throughout the performance of the procedure. Essentially, the supervising professional needed to not necessarily be present in the same room during whatever service is being taken, but needed to be immediately available. So they couldn't be virtual, right? So in connection with the PhD waivers, now CMS had temporarily changed this to allow that supervising professional to be remote and use real-time interactive audio-video technology. That change did not require the professional's real-time presence, right? Which makes sense. Now, this change was temporary because CMS was concerned about this widespread direct supervision through virtual present really isn't going to be safe in many clinical scenarios. So in its proposed rule, CMS rejected requests to make virtual direct supervision a permanent feature in Medicare. Now, CMS is considering whether or not it should make virtual direct supervision a permanent feature of Medicare at some point in the future. We just don't know where this is going to go. And so I would say that if you have data around this, or if you're interested in commenting on this, it's very important that you have and take the time to make comments to this rule. Because again, this is just a proposal. So the more of us that come on and say, hey, this is the circumstances that this makes sense, we may actually have an opportunity to make some changes before these are finalized. So again, in this proposed rule, right, the virtual direct supervision will expire at the end of the calendar year in which the PhD ends. So obviously, I don't think the PhD is going to end sometime this year, right in 2022. However, if it did, say it ended in October, then the supervision waiver would end in December 31st, 2022. Now, if the PhD ends in January of 2023, that of course is going to extend it through the end of 2023. So CMS is also saying that they're extending the coverage of the temporary telehealth codes until that 151 days after the PhD ends. So really, there were a number of temporary telehealth codes and services that were added to that Medicare telehealth services list during the PHC, but this was all meant to be on a temporary basis. So coverage of those codes had been scheduled to end again when the PhD ends. So under this proposed rule for 2023, they're saying, well, hey, we're going to extend coverage of these temporary telehealth codes until 151 days after that PhD ends. So CMS is doing so for basically being inconsistent with that CAA, that Consolidated Appropriations Act from 2022. So CMS is stating that this extension may simplify the post-PhD transition by applying that same coverage end date to all of the various waiver-related telehealth codes in a hope to reduce the billing errors, which I know is going to be a lot for anybody who is doing billing. Now, there are some Category 3 codes, which I'll talk about in a minute, that are set to expire at the end of 2023, while some of these other temporary telehealth codes are set to expire 151 days after the PhD ends. So this is going to get confusing, right? Because depending on when the PhD ends, you could have some codes that expire that 151 days after the PhD ends and others that are expiring at the end of the year. So we're going to have to keep a very careful eye on the calendar to ensure billing practices are kept up with all of this. And again, who knows what the private payers are going to do. So all of this is really up in the air. So again, it's really important that your team is tracking the denials, tracking your payer policies, especially as we go into the end of 2022, which is crazy to even say, and as we go into 2023. Again, all of this could change. We could be looking at that House bill that's going to the Senate, and that changes everything through the end of 2024. So lots to come on this. Now, there were some codes that were added to this telehealth list. So again, CMS created this new category of codes for Medicare-covered telehealth services that was supposed to be on a temporary basis. And these were all called that CMS Category 3 list, which I mentioned earlier. So they were trying to say, hey, we think these codes add clinical benefit when they're given by telehealth, but really we don't know if they have enough evidence to justify permanent coverage. So CMS in this proposal for 2023 actually added 54 codes to that Category 3 list for 2023 specifically. And these kind of fall into a number of different categories, anywhere from therapy to electronic analysis of implanted neurostimulator pulse generator or transmitters, adaptive behavioral health treatment, behavior identification assessment, behavioral health, even some ophthalmology codes, cognition, ventilator management, speech therapy, and audiology. So again, I will put in the show notes the complete list that can be found. So again, this is that temporary code list, right? Category 3 is temporary code list for telehealth. So keep in mind, these codes are going to expire at the end of 2023 should this proposal be approved. So these category 3 codes were originally slated to expire at the end of the year that the PhD ends, which, gosh, that could be this year. Who knows? I guess we'll see what the next couple months show. But CMS did to say that that's going to be too confusing. Let's extend it to the end of 2023. And that's when all of those category 3 codes would expire. All right, let's shift gears a little bit and talk a little bit more about the telemental health requirements that are coming down. So in 2020, Congress imposed new conditions on telemental health coverage under Medicare. They created an in-person exam requirement alongside coverage of telemental health services when the patient is at their home. So under this rule, Medicare will cover a telehealth service delivered while the patient is located at home if certain conditions are met. And really, this was about the physician or the practitioner conducting an in-person exam of the patient within 6 months before the initial telehealth visit, and that the telehealth service is furnished for purposes of diagnosis, evaluation, or treatment of mental health disorder. Or, for example, another diagnosis of substance abuse disorder or a co-occurring mental health disorder. And the practitioner has to conduct at least one in-person service every 12 months of each follow-up telehealth services. So now if these conditions were all met, as well as, of course, other claim requirements that are generally necessary, then the telehealth service would be covered by Medicare, even though the patient's home is not a qualified originating site under the initial statutory coverage laws. So essentially, we're saying that if you are furnishing telemental health services, then it needs to be, you got to have a 6-month before visit. You've got to be working through a diagnosis, evaluation, or treatment of a mental health disorder, right, which would include substance abuse disorders, or any sort of circumstance where the patient has another diagnosis plus a mental health disorder. And therefore, there would not be a distinction between telehealth and non-telehealth services. So this rule was originally scheduled to take effect the day after the PHE expires, but for the amendment for 2023, they're actually saying this would go into place 151 days after the PHE expires. So that's where this is going to come into place. Now, there are some exceptions to this. So there are situations where this in-person exam requirement really does not apply. And so I'll go over each of those. And these are the examples provided by the CMS in this proposed rule. So you're not going to have to do these in-person exams if the patient is located at a qualifying originating site in an eligible geographic area and the arrangement meets the statutory requirements for telehealth service under Medicare. Therefore, you're not going to have to do an in-person requirement for that. So again, this is about specific rural areas, right? In addition, the in-person exam does not apply to telehealth treatment of a diagnosed substance abuse disorder or a co-occurring mental health disorder where the Support Act really states that this would be something that would not be required, right? So the Support Act, I'll make a link to this as well so you can take a look. But again, it's just another thing that would allow some variability or lenience, I should say, to this in-person exam. Now, if the patient and practitioner agree the benefits of an in-person non-telehealth service within that 12 months of the mental telehealth visit outweigh the risks and burdens associated with the in-person telehealth visit, then that's another reason that you cannot do it, right? So they're really giving a lot of leniency, again, in this mental health, substance abuse disorder realm where you're saying, gosh, I'm not going to have to necessarily do that in-person visit in order to get paid by Medicare. Now, again, this is all Medicare. You've really got to make sure that you're understanding your private payers and understanding how all of these rules coming down that are really kind of in this gray zone proposal area, and see what happens. So again, I'm explaining to things how they are stated today, but we are going to see how the next couple months go, and I'll come back and share more information as I get it. So there are going to be some scenarios where you can document to waive that follow-up per in-person exam. Like I mentioned before, it's really about the risks and the benefits associated with that in-person service that may outweigh the benefit of actually having the telehealth visits. So this can be things like a disruption in service or a delay in delivery of care, or maybe even the worsening patient condition. So say you've got a clinical scenario with a patient, you need to do telehealth visits, and you're hitting that window of when you need to do an in-person exam, but you're documenting that you can't actually do the in-person exams for X, Y, and Z, and you're going to need to be specific, right? Just in case you get audited, just in case you need to submit these. And so you're really going to want to make sure that the physician or the practitioner is stating, in their professional judgment that the patient is, clinically stable, and or that the in-person visit has the risks of worsening that patient's condition, and therefore that telehealth visit is going to be applicable. So again, document. So how are you going to document that the telehealth visit is for the diagnosis, evaluation, or treatment of mental health disorders? You guys should know this. It's ICD-10 codes, right? So please make sure that you're documenting the right ICD-10 codes for these types of cases, and that you're being as specific as possible, right? We talk about things in regular E&M codes that you need to be specific. Like, for example, ICD-10 code for obesity or elevated BMI. Those things are going to be harder to get reimbursement for in circumstances where you can be more specific, for example, hypertension, diabetes, et cetera. So this is just another example that you really need to make sure that your ICD-10 codes are on point and as specific as you can be. Now, if you do have an in-person exam and you are going to furnish that, who must conduct that in-person exam? And so the final rule actually suggests that the practitioner would conduct both the first in-person exam and the initial telehealth services. Now, for these follow-up in-person exams that are supposed to happen every 24 months, a clinician colleague in the same subspecialty, in the same group as the physician or practitioner, can furnish the in-person non-telehealth service to the patient if the original physician or practitioner is unavailable. So this flexibility is great, right? And is fitting with the rest of CMS policies, which define an established patient as an individual who receives professional services from the physician or practitioner or another physician of the same specialty and subspecialty who belongs to the same group within the previous 3 years. So again, this is nothing new. I think it's just all in the same, wording basically for the telehealth services. So why are we even dealing with this in-person exam? So why is CMS bringing this up? So actually, CMS did not create this. Congress compelled CMS to implement this regulation following certain statutory changes in that Consolidation Appropriation Act. And so again, I'll add the link to that as well as some links that help me prepare for this podcast, because I think that there are some great information out there, some great FAQs. Of course, I like to share kind of my spin on it, but I'm hopeful that you guys find this helpful and that you can use the links to kind of further your knowledge should you have questions. Again, there are some great legal teams out there that if this is all you do, you may want to consult with them as you kind of plan the next 12 to 24 months. A lot's up in the air right now, and we just have to kind of be nimble to that, make sure that you're paying attention to your current policies in place, and then let's pay attention to these new bills that are coming through the House and the Senate and so forth. So in December 2020, Congress imposed new conditions on telemental health coverage under Medicare, which is actually what really created that in-person exam requirement. And so I know there's a lot of confusion around this. Again, there are certain circumstances where that in-person visit is excluded. Like I mentioned, substance abuse disorders, documentation that it's, not for the best interest of the patient. And clinically, you can actually say that from a professional standpoint, not just from a convenience standpoint. So what can you do next, right? I will come back, I promise, with the 2024 bill that's being put into place into the Senate. I don't see a date yet. I even looked today. So if you are interested in commenting on these 2023 proposal, CMS is actually asking for comments to be submitted before the proposed rule through 5 p.m. Eastern on September 6th, 2022. So September 6th, 2022, put it in your calendar. I'll put the link on where you can go to add comments. Again, I want to thank the resources I used for this. I will link those in the show notes. This was a lot of information. I know that this is all still up in the air. So certainly if you have questions, don't hesitate to reach out and I'll try and direct you as best I can. As always, if you are looking for a medical billing team, we are here. We understand both the clinical and financial aspects of running a practice. And we've been really enjoying working with some great clients this year and really hoping that we are changing not only the view of how we think about reimbursement, but also educating physicians. And if you have in-house billing teams, certainly make sure that they are up to date. They're looking at the changes. They're paying attention. They're giving you metrics. You guys know I love metrics. So hopefully this has been a good episode and look forward to talking to you next week.